Robert is the CMO of Medtronic Diabetes, and he is also the professor of medicine at Uniform Services University
Start
of
the session.
Sciences.
It's
He was
already
the valedictorian
8:55.
of Boston University of School of Medicine, and he has established the Endocrine Society's Clinical Practice Guidelines Committee and served as its chair for 6 years. He was also the Endocrine Society president from 2009 to 2010. He has been active in Diabetes Technology Society, which gave him its Leadership Award in 2011, and he has over 310 scholarly papers to his credit. So now I hand over the mic to Dr. Robert to start his presentation.
Well, thank you very much, Dr. Parikh, and thank you very much, Dr. Sabu, for asking me to participate in this very exciting conference. And I just learned that there are over 30,000 people who are registered, so it's very impressive. I'm going to share my screen now, and we'll get started in a second. Okay. So what I'm going to talk about today is the progression that we have made at Medtronic towards an artificial pancreas system. As you know, Medtronic has played a leadership role in diabetes technology for over 30, 40 years. And I'm going to highlight some of the advances and some of the data that go along with those advances along the way. And you may ask, well, why do we need this type of advancement? And I think most are very familiar with this slide. I think it's the most popular slide that has been shown in the last year and a half since it was published. And this is a graph of the results of a survey from the T1D Exchange, which is a registry in the United States of 21,000 children and adults with type 1 diabetes from 81 of what is considered to be arguably the best endocrinology and diabetes centers in the US. And what you can see here is a graph of the A1C over the age continuum. And in the orange is the data that this same T1D exchange collected in 2010 to 2012, and then in the blue from 2016 to 2018. And I take at least 3 lessons from what this says. First, it says that we have a big problem in our young teenagers, children, teenagers, and young adults, where their A1Cs are spiking up to 8.5 to 9.5. We have a situation where the population, again, arguably in the best diabetes centers, even in adults as they get older, don't reach the goal of 7%. On average in these centers. And what is most dismaying is that it actually looks a bit worse in the 2016 to 2018 time period than it did 6 years earlier, suggesting that at least up to that time, the technology, which has a high penetrance in these diabetes centers, really hasn't made much of a difference. And again, this was at the latest slide. The latest survey was just as the 670G was coming out, so it doesn't include the data and the accomplishments of the first hybrid closed loop system, which I'll talk about shortly. But this is why we need technology. And I believe that until we have a cure, it's going to be the advances in technology that are really going to make a difference. Now, this slide, which I'll show you several times, gives you an overview of where the technology has come from and where it has gone. And you can see on the left-hand side of the slide some of the historical now advances from the first sensor-augmented pump almost 15 years ago to a first threshold suspend pump where insulin was suspended at a threshold. And then the one I want to just show very briefly is the data from the first predictive suspend, which is the MiniMed 640G. So this algorithm takes the intelligence of prediction to the next level. So in threshold suspend, when you hit a threshold, insulin infusion stops. There's still insulin on board, so the glucose can still go lower. and it can be suspended for up to 2 hours. And this is like having an airbag where if you hit the car in front of you, the airbag deploys. Your car may be wrecked, but you can walk away safely. Threshold suspend operates quite differently, where it predicts based on the rate of change when you will hit the threshold and stops insulin, even if the glucose is still in the normal range, and then restarts it at the time that it starts to increase. And this is similar to the safety brakes that we now have, which can sense that you're going too close and start to the car in front of you, so you never hit that car and the airbag never deploys. So that's the threshold suspend and the predictive suspend. How does this predictive suspend actually work? Some of you may be familiar with the SMILE study, which I think, in my opinion, is one of the most spectacular studies in diabetes ever conducted, as you'll see from the results. This was a randomized controlled trial of the MiniMed 640G, so this had the predictive suspend, and they took people who had increased risk of hypoglycemia because they were hypoglycemic unaware or had severe hypoglycemic episodes in the previous 6 months. It was randomized between that thresholds, between the predictive suspend and just the pump alone without CGM. It was over 6 months in 5 countries, 16 sites, and you can see the design of the study on the lower right. And what did they find? Well, they found that there was a 73% reduction in the number of hypoglycemic events, less than 55 or 3 millimoles during the study period in those who had the predictive suspend. The events were significantly shorter, and the time spent in hypoglycemia was 79% less. And more impressive was that the HbA1c levels didn't go up significantly because the suspend feature was thought perhaps might, if you interrupt insulin delivery, it might go up, but it actually didn't. And the rate of severe hypoglycemia, as defined by an actual event, needing assistance, seizure, or coma, was 84% lower than it was in the control. So I, again, would think that I have not seen, maybe since the DCCT, as an impressive randomized controlled trial as this one, showing the power of this automation of predictive suspend. So that brings us to the first hybrid closed loop system, the MiniMed 670G. And the feature that MiniMed 670G has is auto basal. So every 5 minutes, the basal rate can change. And what this is shown on this slide is that now the variability in glucose, and this is the sensor glucose over 24 hours in a patient, showing it's pretty flat. And that variability is now seen in basal insulin. So you see periods where the basal insulin goes up, it goes down, it's suspended. And now that we have transferred variability in the actual glucose to variability in insulin delivery, which now operates on a feedback system. Now, this single patient illustrates this, I think, best. Here's 4 nights in a single patient during a week. And what you can see is that the sensor glucose is flat throughout the day and night, as seen here. Well, this is through the night from midnight to 6 a.m. But you see that each day or each evening through the 6 a.m., the basal insulin delivery is different. So no 2 nights are alike. And there's no way without this automated basal insulin every 5 minutes that you could have predicted when you would have needed to suspend, when you needed a higher basal rate. And most people have 1 or 2 overnight basal rates who are not on automated systems. And I'd like to say that in the United States, where we have snow, we say that there are no 2 snowflakes that are alike. Well, in diabetes, I think this demonstrates that no 2 nights are alike in their need, in one's need for insulin delivery. And so by having an automated system that adapts to the needs, you get these flat glucose curves. Now, the results of the pivotal trial that was run in the United States was designed as a safety study. So it was a run-in period of 2 weeks followed by a 3-month at-home study period. And this is the cumulative percent A1Cs for all the study subjects, and the curve is shifted to the left so that at baseline, only 38% of those met the goal of 7%. And by the end of the study period, 62% had reached that goal. This is in adults and adolescents. And in pediatrics, it went from 36 to 51%. And here are the mean data. Mean went from 7.4 A1C to 6.9 in adults. And on the right, it went from 7.9 to 7.5. And most importantly, in over 22,000 adult and pediatric patient days of exposure, there was 0 severe hypoglycemia and 0 diabetic ketoacidosis. Now, here's the modal day display in orange. This is the run-in phase. And what you see during the study phase is a number of interesting things. You see that in adults, most of the improvement is in hypoglycemia. In adolescents, most of the improvement is in hyperglycemia during the day. And in children, most of the improvement is in hyperglycemia overnight. And that, we think, is because parents of young children let their children's glucoses run high during the night because they're afraid of severe hypos during the night. And they let their children have higher glucoses than are ideal. But with this automation, you can bring this glucose down to the target of 120 by the morning and do it safely. And I think this speaks to the individualization across the age continuum of how these automated systems are actually working. So they work to what the need is for glucose control, and in each of these 3 age groups, they're quite different. Now, if you recall, the DCCT study was very successful, but it was successful at a price. So this is the hemoglobin A1C on the x-axis and the rate of severe hypoglycemia on the y-axis, and severe hypoglycemia here is defined as needing assistance, seizure, or coma. So here's the A1C goal, and in DCCT, it almost reached that goal. This was 1983 when the study actually started. And the severe hypoglycemia rate was 62 per 100 patient years. And in subsequent trials that I've put here with CGM, the STAR-3 trial, the JDRF CGM trial, STAR-3 trial, they all brought down the severe hypo rate and approaching, again, the A1C in the case of JDRF of 7%. But the 670G trial actually got the A1C to just below 7%, and there was 0 severe hypoglycemia. So I think this, in a picture, tells the story of how technology has brought us to improve glycemic control based on A1C, but also improve glycemic control in terms of severe hypoglycemia. Now, on this slide are the results of the pivotal trials of the 670G across the age continuum. So the time in range, this is the stacked bar array that was adopted by most professional societies now, and as a result of the International Consensus Conference, which took place in Paris a couple of years ago. And you can see that in adults, it was time in range of 70 to 180 of 74%, with a very low time below range of 70 of 2.3%. In adolescents, it was 67%. In children, 7 to 13 or 65%, and the youngest children, almost 64%. And this was the result of pivotal trials. But the question is, do pivotal trials really reflect what might be going on in the real world? And here's real life data in 119,000 patients in the United States, in whom we see that their time in range, and most of these are adults and adolescents, and a few children, because it was just approved at the time of this data collection, but 71% time in range, which is pretty close to the average of what the adults and adolescents were. So I think this data gives us comfort in understanding that, at least in the case of this technology, these pivotal trials do reflect what happens in the real world. And in fact, with respect to hypoglycemia, there's actually a lower hypoglycemia rate than there was in the pivotal trials. Now, the only other commercially available system in the United States that uses a hybrid closed loop is the tandem control IQ. And you can see the percent time and range in the control group, in their randomized trial, and in closed loop. And their results were that their closed loop system increased time and range to 71%, as shown here on the right, and the A1C just above 7% for the group. And you can see also here in the modal day that the time and range improved during the night, as one would expect, and it does in all these systems, because during the night people aren't eating, and therefore the systems can actually do their best at controlling basal insulin and glucose levels. Now, the next step in this iteration from the standpoint of Medtronic is the advanced hybrid closed loop. So this has now been CE marked in Europe and has been commercialized. And it really makes, there's several differences which I'll discuss in a second. But this is the next step in getting to a personalized closed loop, which I'll describe at the end. So what's the difference between this advanced hybrid closed loop, which is called the 780G, compared to 670G? It has a lower algorithm set point of 100 instead of 120. And this is the lowest set point that's available in any commercial system. Importantly, it has auto-correction of hyperglycemia, and it auto-corrects down to 120 milligrams percent and does so every 5 minutes. And I'll show you an example of that in a second. And then there's increased stability of auto mode so that people stay in automation for a longer period of time, which of course allows the system to take advantage of the algorithm. Now, every day, patients struggle with their diabetes. And I'll go into a little bit more of this, but I think this little note that a child wrote down about how she was coping with what she was going to eat at school for lunch and how many grams of carbohydrates. And we know that 76% of people feel carbohydrate counting is burdensome, that typically patients with type 1 diabetes miss at least 2 meal boluses a week, and that we know will cause an increase in their A1C. And we know that 2/3 of persons with diabetes underestimate their carbohydrates. So when we're designing a system, we not only want to make it their glycemic control better, but we want to make it easier and unburden them. And that's one of the things that the advanced hybrid closed loop or 780G system does. And here's an illustration of how it does it. So if you don't have diabetes and you eat a meal, your blood sugar goes up over the first hour or so, and then it comes back down. It never goes above the normal range. If you have diabetes and you don't take your insulin, of course, it goes up and it stays up. And depending on, even if you do take your insulin, it's not going to be ideal if you underestimate the carbohydrates or if you take the insulin late. With the hybrid closed loop 670G, what you get is an automated increase in basal rate of every 5 minutes, and that mitigates the increase in glucose compared to what you see on the left. But with advanced hybrid closed loop, you get auto bolus. So on top of the auto basal, every 5 minutes you get extra insulin. So again, it mitigates the rise and brings it down more quickly. And this is much more physiologic than what was previously we had in 670, and really achieved some very important results that I'll show you shortly. There have been 3 studies of this system, a US pivotal study that Anders Carlson at University of Minnesota was the PI, a study in New Zealand from Martin de Bach at Otago University, and a study called the FLAIR trial, which was an NIH-sponsored study led by Rich Bergenstahl. And each one of these were differently designed, different age ranges, and I'm only going to have enough time to talk about the US pivotal study, but each of them were presented at the American Diabetes Association in June, and publications will be coming out with them on each of these in the next month or so. So in the US pivotal study, the overall improvement in glycemic control was to get a time in range to 74.5%, a decrease in A1C of 0.5%, and you can see the improvements in time above, time in, and time below range here. But interestingly, because of the ability to tune the algorithm by adjusting the active insulin time and adjusting the target, in those who had the most aggressive, which we are recommending these settings be used, 2-hour active insulin time and 100 milligram per deciliter target, almost 79% of people in this pivotal trial got to a time in range of 70 to 180, and at not sacrificing the time below range, as you can see here. And the same is true in terms of adjusting the active insulin time, even if you set it at a higher set point, 120. But this is the target that we're aiming for at 80% or greater. It almost reaches that, and it does so at settings that are 2 hours and 100 milligrams per deciliter. Now, if you look at this on a population basis, again, we see that the A1C was achieved at baseline in 29% of the subjects, went up to 47. If you look at the GMI, and you look at the GMI reaching 7%, that's the glucose management indicator, in 52% of the subjects at baseline. At overall, it improved to 72%. And if you optimize the settings, it's up to 84%. And then the time in range goals, which we set at 70%, go from 45% of the population up to 79% of the population. So if you're looking at this not only on an individual, but on a population basis, you're basically getting the vast majority of patients to the A1C or the GMI specifically, and the time in range goals that have been set by the various professional societies. And finally, I want to talk a little bit about personalized closed loop. Personalized closed loop is just what it sounds like. The algorithm will be updated as needed. So there's the data is being collected in the cloud. It's being compared to optimized settings. And as those settings can be optimized safely, they're going to be sent back down to the pump so that in the end, no two people will have the same algorithm. There's also automated meal handling, which is meal prediction. And this device has received breakthrough device designation from the US FDA. One of the ways the meal prediction is going to be verified is with the use of a motion algorithm attached to incorporated into a smartwatch. So each of us has gestures that denote when we're beginning to eat and how quickly and how much we're eating. And this will be incorporated into the algorithm. So meal bolus insulin can be started and stopped appropriately. So this is a high-level view of, again, a little bit of a historical comparison of where we've come from and where we're going. And I think this is really very humbling because it's happened so quickly. So if you look at studies in which MDI and fingerstick blood glucose monitoring has been used, time in 35% at best. If you add CGM, it gets up to 51. If you combine pumps and CGM without any of the closed loop features, you get up to 55%. If you have the closed loop predictive suspend, you get up to 63%. In the 670G and in the US now 770G system, you're up to 72%. The tandem control IQ is 71%. Advanced hybrid closed loop is between 75 and 79% with optimized settings. And the personalized closed loop, we believe, will be able to deliver reliably 80+% time in range. And don't forget, this has all come over a period of less than 5 or 6 years. So what about the burden of diabetes? We can get better better results, but in fact, we want to also get a better patient experience. And if you just take a high-level look at this, this is what people with diabetes have to take care of every day. Literally, they're living with decisions and making decisions about everything that they do, everything they eat, and this just is overwhelming to say the least. So if with 670G, some of these chores and tasks have been taken into account, and their burden has somewhat been relieved. If you look at 780G, which is the advanced hybrid closed loop, you see in the check boxes now in red that many more have been taken into account. And then finally, with personalized closed loop, with meal prediction and meal simplification and smartphone control, you can see that many of these things, if not almost all of them, are going to be taken into account, greatly relieving the burden of diabetes at the same time getting improved glycemic control. And finally, one of the things that Medtronic has done is developed an extended wear infusion set. So using innovative technology, which addresses insulin degradation and preservative loss, we've developed an infusion set that now lasts up to 7 days in over 80% of people. And this goes from what is now about a 2 to 3 day wear. Not only does this reduce burden, but also saves vials of insulin because you don't have to change the infusions set every 2 to 3 days, and it also reduces the amount of plastic waste that's being thrown away. So with that, I want to thank you very much for your attention, and again, thank the organizers for inviting me.